infertility, hormonal contraception, and the ethics of informed consent. So my presentation will speak on what you see in the slides as the core, the problem, the science, the gap, the solution, the action, and then hope and autonomy for women in health. So the core is a call for a holistic, ethical approach towards reproductive health care in Zimbabwe. The notion being, or the point being, to have an thorough informed consent in order to really empower women in Zimbabwe in the field of contraception. So right now I will talk about the problem, and I believe there's a silent crisis currently in Zimbabwe in terms of contraception uptake in Zimbabwe. And right now, the question that really needs to be answered is that the statement that needs to be emphasized on is hormonal contraception may silently impact fertility, especially its long-term use. So right now, I'll briefly talk about the interesting stats to do, particularly with Zimbabwe and Zimbabwean women who are in the reproductive age. And here, the reproductive age is between 15 and 49, and this is according to the Ministry of Health in Zimbabwe. So according to the UNFPA, which is the Population Fund, the United Nations Population Fund, and this is according to a report in 2021, Zimbabwe has a contraceptive prevalence of 68% of modern contraceptive methods. And this is amongst the reproductive age that I spoke about, which is 15 to 49 years of age. And then also according to the Zimbabwe Health Ministry report, the same report in conjunction, the Zimbabwe Ministry of Health report in conjunction with UNICEF and UNESCO. The report was on adolescent health, adolescent women's health. And they found that Zimbabwe has the third highest prevalence rate of uptake of contraceptives. The 68% I mentioned makes Zimbabwe the third highest in Africa. And in that same report, they found that teenagers aged between 10 and 19 years actually the most prevalent users of these modern contraceptive methods. And the most commonly used contraceptives being the pill, which is the progesterone-only pill, or the combined contraceptive pill, which is progesterone and estrogen pills, and injectables, particularly Depo-Provera, intrauterine devices, particularly the one that produce levonorgestrel, and then implants like Jadel, the one that is 5 years long, and implant, the one that is 3 years long. So all these contraceptives are actually hormonal contraceptives. Either they produce progesterone or progestin, which is a synthetic form of progesterone, and then and we all know that progesterone keeps the body in a constant pregnancy state, and that is how the contraceptive works in contracepting. And then the other one, hormonal contraceptives, also produce estrogen or ethanoestradiol, which is a kind of estrogen, and it's synthetic, and that is one of the estrogen components found in these contraceptives. So now looking into the science, we want to look at hormonal contraceptives and fertility risks. And I will first speak about endometriosis. So what we want to find out is what's the connection between contraceptives and endometriosis and its resulting fertility risks. So endometriosis, as you know, is a chronic inflammatory disorder characterized by the abnormal growth of endometrial-like tissue. And this is outside the uterine cavity. And this affects 10 to 15% of women of the reproductive age. And this 10 to 15% is according to the World Health Organization. And this one is the global percentage. So combined hormonal contraceptives, progesterones, etc., are the current options for hormonal therapies for endometriosis. And then medical treatment for endometriosis typically does not eliminate the disease, according to current studies. And they often involve side effects and can hinder reproductive desires of patients, which is infertility in this case. And then chronic pelvic pain, which is the main symptom of endometriosis, frequently necessitates repeated courses of medical therapy. And then medical therapy in this case is the hormonal therapy that I was talking about. Surgical intervention or both, with symptoms commonly recurring once the therapy is stopped. And now, which brings in the question, if the symptoms are recurring after therapy, hormonal therapy in this case is used to manage endometriosis, and with the risk of infertility, is it the only way to manage endometriosis that should be introduced to women in Zimbabwe and even globally? So in this first picture to your right, you notice that it's showing management of endometriosis symptoms in this case. And as I said, chronic pelvic pain is one of the major symptoms of endometriosis. And for this, the main ways to manage it is the medical way, which is hormonal therapy, as I mentioned. They also use analgesics or non-steroidal anti-inflammatory drugs are also used, but currently the main one, especially in Zimbabwe, would be hormonal therapy. And then as we ask the ethical questions of the recurring symptoms of endometriosis is, even after therapy is stopped, in this case, hormonal therapy, the question we need to, or the questions or the way forward we need to come up with is maybe introducing new potential therapies, which are highlighted here in the diagram below to your right. Maybe look at immunotherapies, anti-inflammatory oxidant drugs, or repurposing drugs that are existing. In other words, looking at a non-hormonal approach. Again, under the science, looking at hormonal contraceptives and uterine fibroids in this case, and their potential fertility risks. I'll talk about uterine fibroids. So for uterine fibroids are monoclonal benign tumors. In other words, they're not cancerous, of the uterine smooth muscle that originate from the myometrium. And uterine fibroid cells are known to respond to estrogens and progesterone stimulus during the reproductive age of women, which means they are hormonally dependent. And so medical treatment of abnormal uterine bleeding, which is the main symptom of uterine fibroids, with hormonal therapies demonstrate no particular clinical reduction in uterine fibroid growth and reproductive failure. They only control abnormal uterine bleeding. So in as much as in terms of management of uterine fibroids, and we manage the abnormal uterine bleeding, in terms of the actual uterine fibroid growth or the risk to fertility, the hormonal therapies have been found currently with current studies that there's not much effect. If at all, there might be risks to fertility, especially with long-term use of hormones as a means to manage this abnormal uterine bleeding. So right now in research for uterine fibroids, focus has shifted to progesterone-related pathways due to evidence showing that one of the main roles of estrogen may be the induction of progesterone receptors in uterine fibroids. And what has been found in current research is that a high density of progesterone receptors may stimulate leiomyoma growth, which is uterine fibroids. So the combination of estrogen and progesterone hormonal therapy in current research is actually showing that it's in inducing progesterone receptors that actually then stimulate uterine fibroid growth. So in the diagram to your right, you can see that medical management, the main medical management of uterine fibroids like endometriosis currently is hormonal therapies, and that is introducing estrogen and progesterone via contraceptives as a means to manage abnormal uterine bleeding, the main symptom of uterine fibroids. But as I said, current research is actually showing that under long-term use of contraceptives, we might actually induce progesterone receptors that stimulate uterine fibroid growth. So maybe the very pills or the very contraceptives that are meant to plan families could, for some, make conception harder much later. So now I will talk about the gap, which is the ethical gap in this case, in terms of informed consent in Zimbabwe. The question being, are women in Zimbabwe truly informed about endometriosis, uterine fibroids, and hormonal contraceptives that are used as a means to manage the main symptoms of both endometriosis and uterine fibroids? So I'll speak about the current gaps. So right now, one of the current gaps is that there is lack of discussion on long-term risks of long-term use of hormonal contraceptives, especially with regards to endometriosis and uterine fibroids, which are correlationally known to be involved in infertility in women. There's also limited access in-depth education on non-hormonal options, for example, natural family planning methods. And then in the 2018 family planning guidelines for Zimbabwe, these were introduced in conjunction with the World Health Organization and the United Nations Population Fund. NFP methods are recommended. Yes, they are recommended, but they are also recommended with the use of a hormonal method. So in as much as natural family planning methods are there in the family planning guideline in Zimbabwe, the issue is that they are also being recommended with the use of one or two methods of that are hormonal in nature. The other gap is that there is no thorough research that has been done in Zimbabwe currently to find out the percentage of women reporting not receiving full risk information on contraceptives. There's no thorough research also on the prevalence rates of endometriosis and uterine fibroids. In terms of uterine fibroids, I'm from colleagues who are radiographers in provincial and general hospitals across the nation of Zimbabwe. This has been anecdotal from the radiographers, but is a telling sign. So from 2018 to today, radiographers in Zimbabwe in provincial and general hospitals, which are government hospitals that actually receive the most patients in terms of women in the reproductive age, are reporting an uptick in uterine fibroids. So is a country that is recording uptick in uterine fibroids, according to radiographers in the country, there's no thorough research on this prevalence to really find out what are the prevalence rates of endometriosis and uterine fibroids in Zimbabwe. And then there's no thorough research also on the prevalence rates of infertility in correlated to endometriosis, uterine fibroids. And this is a concerning issue for a country with a high contraceptive uptake. The uptake that I talked about, the 68%, which is the third highest in Africa. high contraceptive uptake is there in Zimbabwe, but there's no research to follow through on that high contraceptive uptake. And then now to talk about the solution. And the solution here that I'm suggesting is rights-based family planning, which is a better way forward. So I propose four particular directives in this case. So the first directive is transparent consent protocols. So within our government hospitals, particularly because they received the largest number of patients for the women in the reproductive age, emphasis should be on all family planning methods, including natural family planning, clear verbal written risks of all the family planning methods, hormonal and non-hormonal. Government hospitals should also include pamphlets that they can give out to women for free with all this information, and the pamphlets should be in our local languages and not just in English, in order to reach even women in our rural parts. The second directive will be access to non-hormonal options. There should be investment via the government, the World Health Organization, the United Nations Population Fund, and in-depth education on natural family planning methods in nursing and medical schools in Zimbabwe. The same emphasis that is given on hormonal methods should be given in nursing and medical schools. Why this is important? Because nurses and doctors are the first line of knowledge when it comes to contraceptives, when it comes to endometriosis, when it comes to uterine fibroids to women in Zimbabwe. And then also introducing the understanding of the female body via natural family methods classes in primary and high school, in high schools in Zimbabwe. Right now in our education system, yes, reproductive health is taught, but for both boys and girls, emphasis should also be on all contraceptive methods, be it hormonal and non-hormonal, and details on menstrual education and understanding the menstrual system for both boys and girls, in order to give them as much information as at a young age, because as I noted before, according to the 2022 adolescent report from the Ministry of Health in Zimbabwe in conjunction with UNICEF, as I said before, 10 to 19-year-olds in Zimbabwe are actually one of the highest groupings in Zimbabwe that are taking on contraceptives, especially hormonal ones. So it's important that classes also target that group in terms of education of the risk factors that come with hormonal contraceptives and also the use of non-hormonal contraceptives. And then the third directive will be research into non-hormonal treatments in Zimbabwe. Like I spoke about in terms of management of endometriosis and uterine fibroids, more research has to be funded in terms of immunotherapies for treatment of endometriosis, so that there's no dependence on hormonal contraceptives in terms of management of endometriosis, and also research in immune and genomic science for the treatment of uterine fibroids, as the uterine fibroids are mostly a genetic condition. So more research on genomic science, especially in Zimbabwe, to encourage that research. And then also the fourth directive will be funding targeted women's health. So government and private funding on targeted women's health research, including large-scale infertility prevalence rates and clinical trials of developed immunotherapies in terms of management of endometriosis and uterine fibroids. So this presentation is for women's health, targeted for women, but also important for men to know. But the call to action here is via policy and empowerment of women through knowledge, and making women understand that their voice matters in terms of their reproductive health. So first port of call is to demand stakeholder, which are the women in this case, the women from as young as 10 years old, to have to inform policies to do with reproductive health, to do with contraceptives, to also encourage women in Zimbabwe to do their own research, whether it's via YouTube, via the internet. Also to ask healthcare providers, the nurses and the doctors, the right questions. So by empowering women through classes, through education, and encourage them to do their own research, it allows women to ask the right questions from nurses and doctors about their reproductive health, especially to do with contraceptives, and then also encourage women to share knowledge, always remembering that it's their bodies, their rights to encourage in the government. And then in conclusion, with an informed women, we build healthier futures, and giving women autonomy builds healthier futures. So we can move from women struggling with side effects of hormonal contraceptives, symptoms of endometriosis, symptoms of uterine fibroids, allows them to have productive years during their productive lives, and also to not have issues of infertility in the case of when they want to build their families. So informed women build healthier futures. So this is just a list of resources for further study for those that are interested. The list here is the family planning guideline for Zimbabwe that I mentioned before, and then the National Assessment on Adolescent Pregnancies in Zimbabwe that I referred to also, and then current meta-analysis research that is on endometriosis and uterine fibroids. And then also in terms of from an African point of view, in terms of our health, I also recommend this show called The Lynn Ngugi Show. It's from a lady from Kenya, and she interviewed two very informed doctors, Dr. Wahome and Dr. Njagi, on endometriosis, uterine fibroids, menstrual cycle, contraceptive, sexuality, education, and these would be really good tools from an African perspective to educate women in Africa and Zimbabwe about their reproductive health. Thank you very much.